So I will welcome everybody to the first seminar in our seminar series for the Lee Kumshung Center for Health and Happiness. I am not sure if this was noted anywhere, but our theme this year is health equity and thinking about the role of health equity in the topics we're studying on psychological well-being and physical health. And the translation of these findings into real-world applications. So we are really delighted to have Professor Mika Kivimäki with us for our first seminar of the year. He is Professor of Social Epidemiology at University College London. He was recently elected as a Fellow in the Academy of Medical Sciences, which is the independent body in the UK representing medical science, whose mission is to advance biomedical and health research and its translation. And as was noted by the Academy, Dr. Kivimäki is a world leader in social epidemiology with particular focus on non-communicable diseases. His aim is to increase understanding of modifiable risk factors and prognostic factors for adult onset chronic diseases of public health relevance. He is editor of the Routledge International Handbook of Psychosocial Epidemiology, which I'm personally very excited about. This is actually the first handbook on the topic, and hopefully going to set a long path of additional writing on the topic. He leads the prestigious Whitehall II study, and his studies have been used as primary evidence for all kinds of clinical guidelines and policy statements, including among many the 2016 European Guidelines on Cardiovascular Disease Prevention and Clinical Practice, the American Heart Association Scientific Statement on Social Determinants of Cardiovascular Disease, and for anyone who hasn't seen those, I highly recommend them. They're really, really well done. And the WHO Commission on Social Determinants of Health. He is also an ISI highly cited researcher with an eye-popping number of publications. I'm not even going to give the number because it's so astonishing. And perhaps more importantly, he's a wonderful colleague. We've done some collaboration with him, and it's really been a pleasure, and he's a terrific scholar. So I'm really happy to introduce him to you today, and I'm going to hand it off to you, Mika.
Okay, thank you. Very, very kind introduction. So social inequalities and physical and psychological health, that's the topic. And this is not very surprising topic for a person who comes from Whitehall, because this has been the main thing in that study for more than 30 years. So actually how it started, I was in a virtual retirement party of Martin Shipley, who was one of the authors of the original paper, which described the employment grade and coronary heart disease. How, if you have a higher grade, you are more likely to, you are more protected against coronary heart disease than those who are in a lower grade jobs. And we discussed all kind of things, and then somehow it went to work things, and also this start of the Whitehall I. This is Whitehall I findings, and Michael Marmot, who was leading the study, said that actually when they started to do this paper, this was the first paper for Whitehall I, it was just pure scientific interest. There was they were not thinking at all implications and these kind of things. It was just in a way, let's write an interesting paper, and this is what they wrote. They had Marmot and Jeffrey Rose, which we all know, and Martin Shipley, who is now retiring, was the statistician there. And they show that there is a gradient. Then someone asked that, because Michael Marmot came from some kind of government meeting which was dealing with these social inequalities, then someone asked that, hang on, when did you understand that this is actually a big thing? So this is something more than just one paper. This is something which has implication and might be a big thing. And Michael said that actually it was when this Black report was published. So Black report was some kind of, they are typically reports which the government orders or would like some independent scientists to make. And the normal system is that then they write the report. Government is very grateful that this is fantastic and so on and so on. And then they put it in a folder and forget. So that's the usual story. But Michael said that this was different. So this was the time when Thatcher was the prime minister, and actually they were very hostile against this report. They were saying that no, never. This is something very unrealistic. This government or no subsequent governments are not able to, in a way, tackle these kind of things. And this was the point, Michael said, that this was the point he understood that, hang on, there is something big now here, and this is worth looking closer. Then they had these further papers. I mean, there were this Jeffrey Rose Marmot paper looking social class and coronary heart disease with a longer follow-up, and then they had this famous paper, which is Marmot, Shipley, Rose looking deaths. And again, they see this crazy pattern here. And then it's not only cardiovascular disease, you see it also for total mortality. And it was not explained by these conventional risk factors. So they thought that there is something more general going on here. And this is something very important to look closer. What then happened was that fairly soon after these, they applied money for Whitehall II study, which is now an ongoing study. And the idea there was that that study is actually to try to find what are the mechanisms which are behind this gradient. And then the other thing was that the original Whitehall I study was only men, and now Whitehall II study is only including women. So that's the history. Okay, so then there are now new studies coming out. This problem has not gone anywhere. So this is a big multi-cohort study, 46 different cohorts from Europe, US, and Australia. And what's remarkable here is that they were at different quality and so on. But they all, in men, all studies, all 46 studies suggest that there is high mortality among those who are in lower SES groups. In some cases, it's not, it's imprecisely estimated, but still you see it's always hazard ratio more than 1. And this is almost the case also for women. So 44 out of 46 studies suggest that low SES is related to high mortality. Big study, the problem has not gone anywhere. So now let's look what we are discussing today. To in a way get a fresh idea what's going on there, I thought that we first look social inequalities in a study which tried to use this kind of outcome-wide data-driven analysis, because typically these studies have been done for specific outcomes, and then you start to wonder what happens if you take all health conditions, you can just get data and look these like any omics study, like GWAS studies and these studies. What would you see there? Is it so that those which you usually see in literature are the only hits there, or are there also other diseases? So we'll discuss about those findings soon. Then another area where there have been some fairly new research is also looking these different kind of mechanisms. So how these social inequalities actually evolve from childhood to early adulthood and midlife. What is the role of health-related behaviors? What is the role of life stress? And then finally, we are looking then old age outcomes, whether we also see there SCS gradient, or is it fading away? And in relation to dementia, which is an interesting outcome because of population aging and population growth, it's increasing hugely from 1990 to today. I think the number of people with dementia has doubled. So this is an interesting thing. But what about, is that also socially patterned? And what makes that that gradient, if there is one? And now we are looking research which is published during the last 3 years. So we try to keep it fresh. I prefer here now multi-cohort studies and studies with big sample sizes, just because in a way to get more precise estimates and to avoid random findings. I think some of you might have seen when the big UK biobank study, which was it's a UK study where there are 500,000 people followed up with very intensive measurements. The way Rory Collins, who is the PI, in a way tried to convince that this is a good approach, having big data. He used an example from on systolic blood pressure and cardiovascular mortality, and showing that, all right, normal cohorts are 5,000 people, and you see somehow this actually known association that higher blood pressure is related to more vascular deaths. But it's fairly, you can't be very sure with 5,000 people. If you add the sample size to 50,000 people, now you start to see it a little bit easier. But yeah, there are actually gradients here, so that the higher the blood pressure, the higher the mortality. And this seems to be something which can be seen in all age groups. But multiply the sample by 10, there's no question anymore. You really see it if there is an association in every age group. The point is here that it makes the random error less likely. But obviously also big studies are open to all kind of confounding and bias and these things, which also characterize smaller studies. So we don't get avoid from those, but we get more precise estimates. And so that's the reason why we are now trying to prefer large studies. Okay, so why to look outcome-wide analysis? So there are several reasons why this could be a useful approach. One is that if you report everything, all your outcomes, all your health outcomes, there is not room for investigative bias, for selective reporting and these kind of things. So that's a plus. Another thing which is good is that if your approach is to report everything, it's very justified also to report null findings, because usually the problem if you send your manuscript to an editor, null findings are much more difficult to publish than positive findings. So, but in this context, it is part of the approach, and that's easier, and which means that the publication bias is diminished. Then another good thing here is that now you have in a way a uniform platform to compare different effect sizes, to compare the strength of association between different outcomes. So that's also useful in a way. You understand much more. It's much easier to understand if there is some kind of outcome specificity and these kind of phenomena going on. And then obviously the good thing is that it's efficient. So basically, if you look everything and you report everything, that's advancing of knowledge quite rapidly. how we try to in a way capture a wide range of health outcomes. We used electronic health records, and now the data are from Finland and from the UK. And the advantage in these two countries is that there is a national healthcare system. It's a uniform system, and both rich and poor people are using it. So basically, there is less this kind of selective data and these kind of issues going on there. And we were looking hospitalization and mortality. Then there were some other additional national registers like drug reimbursement register and national cancer registry, where we get a bit extra data for specific health conditions. Okay, so that's the setting. The numbers are here. So the primary analysis was made using Finnish cohort studies. We don't start to study all these steps in these flow charts, but the bottom line shows that there were a bit more than 100,000 people in the primary analysis, and then we tried to replicate the main findings using the UK data, Whitehall II data, which is a bit less than 10,000 people. And the way we tried to do this is that we wanted to have robust finding in that sense that we used two different SCS indicators in the primary analysis. It was education, it was one, and then the other one was area deprivation. And then when we replicated findings, we used the third SCS indicator, which was occupational status. So now we are trying then to look what are those health outcomes, psychological and physical, which can be seen across all different SCS indicators. And in total, in those registers, we had sufficient data for analysis for 56 different common hospital-treated health conditions. So that's the setting. And these are the findings. So first, more than half of diseases were socially patterned, so that they were more common among those who are in low SCS groups. And 18 of these 56 diseases or health outcomes, you can see this pattern across both indicators, area deprivation and education. So these are very clear relations. And what we also looked, we were not interested in tiny effects, so we only looked at effects which were more than 1.2 hazard, with more than 1.2 hazard ratio. And then we had another 11 health conditions which were related to either area deprivation or education, but not both. And then 23 diseases were not socioeconomically patterned, or the hazard ratio was less than 1.2. And then 3 conditions were in the other direction, so that actually there were more disease cases among those who had high SCS, or in this case, higher education, like melanoma, spontaneous abortion, hypertension in pregnancy, and breast cancer. Some of these are probably indication bias, so that those who are more educated are more likely to be diagnosed with these diseases. Melanoma is perhaps because it used to be fairly expensive to travel and have holidays in South, in Mediterranean countries and so on. That was something which people used to do, and they got more sun and these kind of exposures. Anyways, so we are not interested now anymore from, let's focus on these, what we first found, these 18 conditions, and look whether we can see the same thing in Whitehall data using a third indicator of SCS, which was occupational position. And what you can see here that yes, we can. So the hazard ratios for these conditions were all more than 1.2, so that risk was higher among those who have low occupational grade. And so actually these estimates are slightly higher than in the Finnish dataset. But the bottom line is that although some of these were estimated imprecisely, the point estimate is always more than 1.2. So it suggests that there is a socially patterned incidence in these diseases based on hospitalization records. Okay, so let's see what they are. So one thing that there were quite many of these conditions were mental or behavioral or injuries or external causes. They were like poisoning, mental disorders, self-harm, disorders due to substance abuse, and dementia. So that was a common category. Then another category which was fairly common was endocrine and digestive diseases. Diabetes, renal failure, diseases of the liver, pancreatitis, and so on. And then obviously we see the circular and blood diseases here. So we see both stroke and ischemic heart disease, heart failure, atherosclerosis, and finally some respiratory diseases like COPD and cancer, lung cancer. So quite a range. But still, this looks like a bit like a list, and it would be nice to get a bit deeper understanding what's going on. And so we think that let's look whether these diseases actually tend to cluster to the same to certain group of people rather than be equally distributed in the groups. So we started to look what are the associations between these diseases. So if you have, or health conditions, if you have poisoning, what is your risk of having a hospitalization due to self-harm and so on? And as you can guess, these are really related to each other. So we can see that poisoning, for example, hazard ratio or risk of self-harm, having another hospitalization due to self-harm, 93 times higher. So these you seldom see so high hazard ratios, and many of these are more than 5. So let's try to draw a trajectory of these diseases. This might give an idea what is actually going on there. And so what we did a trajectory which is looking which diseases are predicted by other diseases. And we looked the first time they were hospitalized. So this is mean age of onset. And then we looked what other diseases that disease predicted. And we had quite a conservative threshold here, because in this trajectory we show only those associations where the hazard ratio is at least 5 or more. So your risk, if you have hospitalization due to self-harm, to have another 5-fold or more a risk to have another hospitalization due to substance abuse, for example. And this was the other thing, that here we have picked only those conditions where the five-fold association is seen both in those who are in groups of area deprivation and in those groups where people have low education. And this is what you see. So basically, the first hospitalization seems to relate to these psychiatric, behavioral, external causes type of things. Then you see more these endocrine type of things going on here. Then including renal. Then you start to see vascular events here, heart failure, then respiratory problems, COPD, lung cancer, and the final, the latest onset disease is dementia, which is predicted by substance abuse. We are coming to that later. So there seems to be this kind of trajectory where there are behavioral, psychiatric, mental, these kind of external causes, which then are related to all kind of other health problems, and then finally related to dementia. I mean, this diabetes is quite interesting here because it doesn't come from here. So it is just in a way standing alone and then predicting further vascular problems, but it's not part of the trajectory from mood disorders and these kind of things. Oh, I mean, this fivefold threshold is totally arbitrary. We also try to do have a lower, more relaxed threshold. So we draw all connections where the association is 2.5-fold or more, and that's that's what you see there. So almost every disease is related to another disease. But again, this diabetes seems to come from nowhere. So it's in a way starting point. It doesn't come from anything else. Okay, that's the way to move on. So the next question, we have an idea now what kind of diseases have the strongest association with social social conditions, social circumstances, and now we try to understand why. And we are looking how these inequalities evolve from childhood to early adulthood. Now, the example will be diabetes actually, but so diabetes. But we just started with big data, but now we have to make a compromise here and start to look smaller data, because what we want here is high resolution. We want several repeated measurements to understand what is the sequence of changes in risk factors and health. So is it so that first change risk factors, which then start to change health outcomes? Or is it so that actually the health problems were from the beginning? So we are talking about, is there a causation or is there selection which is creating these inequalities? And the high resolution data is the young Finns cohort study, which started 1980. And it was a population-based study, so that, that the sample included people who were 3 years old, 6 years old, 9 years old, 12, 15, 18 years old. So 6 different age cohorts. And the measurements of 3 years old were not shown here. But then the design was so that this measurement was repeated every 3 years. So we have 3 years apart these age cohorts, and then measurements every 3 years, which is quite interesting and useful design, because now you can do these longitudinal modeling, because you have several measurements at age 6, you have several even more measurements at age 9, 12, 15, 18, and so on, always going on at 3 years interval until up to 48 years old. So nice setting to look trajectories in risk factors and in health outcomes. And this is what we do now. So we start to look how these things change. I hope you see this. So we have here risk factors, and we have here biological measurements. And in x-axis, we have age. So these are mean trajectories across these age groups, smoothened. And what you can see here, if we start in here up, so diet, how much you have vegetables and fruits in your diet. You can see, and the red one is the low SCS group and blue is the high SCS group. You can see that this is actually something, the difference was there in the beginning. So in the beginning already, you see that the diet was more healthy, was healthier in the high SCS group, clearly. And that difference continued until adulthood. The other thing what you see here is that, actually I can't see, but I think that this was physical activity. So there were small differences in physical activity, but in this you can see that the activity dropped in adolescents much more in low SCS groups, and then this difference remained there during the adulthood and early adulthood and midlife. So we see that there are these risk factor differences already very early. We also see that there were differences in smoking. They were small in the beginning in adolescence, but they increased in older ages, in adulthood, although in both cases there is quite a nice decline in smoking prevalence. So we have here 3 risk factors, and they seem to be, the differences seem to be big. And then when we start to look biological indicators, we have BMI here. And this shows nicely that in the beginning of this study, when these people were young, there were no differences at all in this biological parameter, this biomarker. But the only difference was risk factors. But these started to diverge in young adulthood after 20 or something like that. So this really makes sense in that sense that you first have risk factors and then you start to see differences after a delay in your biomarker data. And you see this same pattern in BMI, and blood pressure and triglycerides. HDL, which is quite a lot heritable, you see much less differences. But here you see a nice pattern of first risk factors and then biomarker changes, which is the sequence of changes which supports the causation hypothesis. Now, the more important and more pronounced biomarker is actually related to glycemic control. So we know that insulin is something which moves glucose from blood circulation to our tissues, and one thing which relates to development of diabetes is that your insulin sensitivity start to lower. So it's less than, you need more and more insulin to do the same change, transfer the glucose from blood to tissues. And you can see that in low SES group, this is actually in the wrong way. So yeah, so this is in the wrong way. So basically blue is still high, yeah, and red low, yeah, exactly. So you can see that having these risk factor operating here in the childhood and adolescence, you start to see that insulin sensitivity start to lower among people in low SCS groups. So they are more insulin resistant. And what you see also is that in that group, what the pancreas do to compensate that insulin resistance, it starts to secrete more insulin. So you can see that there is more insulin secretion in the blood. And this is simply in a way to compensate the insulin resistance. And then you see that in spite of that compensatory change here, fasting glucose start to increase in the low SCS group, as you can see here. So they are heading towards diabetes here. In Whitehall, we have done this analysis of looking what happens before diabetes. So we have here we are looking backwards. What happened to these glycemic biomarkers before diagnosis of diabetes? And what you can see here, that insulin sensitivity among those who develop diabetes compared to those who do not is low, is poorer and lower already at least 13 years before disease onset. You see that there is increased beta cell function, so more insulin secretion during the same period of time, and after this inflection point when the insulin sensitivity start to go even lower, there is this compensation so that pancreas secretes more and more insulin, but then is exhausted and then can't produce any more. And there is an insulin deficiency, which then triggers increase in fasting glucose. So that's the story how diabetes develop. And it's exactly what we saw in the low SCS group. And so this finding that low SCS groups, if you look cumulatively, how long they have lived in area deprivation, it's very clearly related to risk of diabetes in adulthood. So by age 48, low SCS people are more obese, they are more hypertensive, they have more hypertension, fatty liver is more common in that group, and they have much more diabetes. There are some indications that some cardiac remodeling has already started, but no differences in plaques yet. But we know that that's what diabetes tend to cause over a longer period of time. Okay, so that's one thing. So this diabetes puzzle seems to be in kind of being born in a setting where you have more exposure to traditional risk factors. Then we have this psychological side, which is life stress, and which relates to these kind of, which is origin for these kind of problems here, which happens in adulthood. And now the interesting question is obviously what have made this? What is behind this? And is it childhood or is it early adulthood which is creating these problems? One way of looking is looking adverse childhood experiences which are much more common in low SCS groups. And what we see here, if we look this very nice review by Huge and colleagues published in 2017, is that these having multiple adverse childhood experiences, i.e. severe stress in childhood, it's related to very strongly to several different kind of diseases. You see liver and digestive disease 2.8-fold risk, respiratory disease more than 3-fold risk, more than 2-fold risk of cancer, STDs 6-fold, endocrine 1.5-fold, cardiovascular doubling, and then all kind of psychiatric things 3.7-fold to 30-fold risk here. So definitely a wide range of risk related to this sensitive period of childhood. It really makes a difference in your future health. If we look the same thing in relation Oh, so there's a very new study. I just would like to highlight this. This is a Danish study published a couple of weeks ago. And this shows a similar thing, but now the endpoint is mortality before age 35. And you can see the same thing, that the risk of mortality, early mortality, is very much related to your deprivation and adversity, childhood, what happened between before age 16. This shows that actually, so this shows the low adversity group, and these are the cumulative risk here, and this is the high adversity group, which is material deprivation, but also loss or threat of loss, and loss here is death or illness of a family member. And you can see that it really makes a big difference in mortality risk, and the causes of mortality are these kind of external suicide, accident, and these kind of things, which fits very well with our trajectory of diseases. Oh, then very different story if we look stress in adulthood. I have studied a lot of stress and in adulthood, and I really envy these people who have done this childhood stuff, because they really have high effect sizes. These effect sizes are tiny. So adulthood stress in multi-cohort studies, this is the number of cohorts in each of these studies. You can see very little gastrointestinal, very little respiratory cancer. These are likely to be chance findings rather than real. Some relation with endocrine diseases like diabetes. Some kind of small or moderate association with cardiovascular stuff, and more stronger association for depression and psychiatric disorders. So that's the view for adulthood stress. But then, if you look carefully, cardiometabolic things, you can see that, all right, if you look just cardiovascular disease, you see that extreme stress in childhood, big risk factor. Then adulthood, if you are looking general population, it does fairly little. If you look high risk population, so people who have advanced atherosclerosis or already have had first attack, then you see quite a big effects here for stress. And we tried to look this closer using this pool of cohort studies. I think there were 12. This shows, so basically we had quite well-powered analysis. And what we did, we did look separately healthy people and then those who had cardiometabolic disease, that is diabetes, first MI, history of first MI or stroke. And you can see that, yes, if you're healthy, adulthood stress really doesn't do big things here. These differences in relation to job strain, for example, in relation to mortality, it makes very little difference. But here you can see really quite clear associations. So if you have these prevalent diseases, stress is very bad for you, especially if you are a man and working age man. And this is how it looks if we look Kaplan-Meier. So these are men with stress and cardiometabolic disease. These are men without stress and cardiometabolic disease. So there is a big difference. And then there have been even trials now, and meta-analysis of trials, which shows that MI patients having these kind of interventions to lower stress actually decreases recurrent events and deaths. Okay, how much I have time? very little. So, I've been a bit slow, but let's have a quick look, at least, what is the shape of cognitive aging when we look SCS and dementia. So it's this thing here, what we are, where we are interested now. In principle, how you can think this is. So basically we have first the developmental phase, our brain is developing. And then we have adulthood when we have age-related cognitive decline. And in some cases, it's accelerated and leads to dementia. And so basically, it's possible to think that how dementia-related SCS dementia association arises in theory, it could be that it's the childhood which makes the difference, so that the peak cognitive performance is higher in high SCS groups. And for this reason, although the cognitive decline with age is the same, those in low SCS group hit the dementia threshold at a younger age, so they have higher risk of dementia. The opposite model is that actually childhood does not make any difference at all. It's more that it's the adulthood which makes the difference. So basically a similar kind of development of cognition, but then less favorable conditions in adulthood makes the difference. And now let's look what the evidence shows. It shows using just observational is obviously open to all kind of errors, but let's now use Mendeleev randomization. And the good thing here is that there is some kind of randomization when we use genetic instruments to look genes which are related to low SCS and high SCS and look whether that makes a difference. In this case, genes which are related to higher education and lower education, and then look whether that makes a difference in dementia risk in old age. So that's why it mimics a randomized control trial. And this is what we see with Mendeleev randomization. So if we look genes which are related to higher number of years of education, are related to college and university education, you can see that these genes are related to lower dementia risk. That it is in a way, the Mendeleev randomization study suggests that there is a causal association with education and dementia. And this might be one of the reasons why low SCS people have higher risk of dementia. Then if we look just conventional observational data, we see the same thing. So lower education is related to higher dementia. So these two findings suggest that there is at least this kind of early life influence operating there. Then we look the same thing in Whitehall, which is also high. It's not anymore a big study. It's a small study, but it's well phenotyped, and so there are every 5 years we have a clinical examination for our people. Actually, we started also one this year, but then COVID interrupted that. That makes it possible to do this kind of retrospective analysis, which are very interesting. So basically, we have here the different measurements, and then people, based on electronic health records, develop dementia at different dates. What you can do then, you start the follow-up actually from the onset of dementia and go backwards. So this is the opposite what we usually do in the prospective design. This is a retrospective. So the year 0 is when you develop dementia. And for example, in these people, then you have data. What was the situation 3 years, 8 years, 13, 18, 23 years before dementia? The date for that person to have dementia was a bit earlier, and then you got, then the clinics gave data from 4 years, 9 years, 13, 19 years before. And when you aggregate all of these, you actually can then draw the trajectory across all these years here. And this is what has been done here. And I must say that these findings were first very, very surprising for us. So what is a good thing and reassuring is that when we look cognitive function, you can see that there starts decline among those people who develop dementia. This is the backwards analysis, some 10, 12 years before the onset of dementia. And this is what we see in people who did not develop dementia. By the way, it goes downhill from year 40 onwards, from age 40 onwards. That's the sad thing here. Anyway, so then when we looked, we thought that it's what we see here is that there is steeper decline among those who are in low SCS groups, but what we see is the opposite. So you can see that when we start from the year of dementia diagnosis, you can see that this is the trajectory for high SCS group, and this is much steeper. And this is a low SCS group, and this is much shallower decline here. So it goes the other way around. We thought that it goes in another way. And the difference is even clearer here when we look dementia by occupation. But now it's important actually to also look this thing prospectively, because now we started to the follow-up backwards at the year when the person developed dementia. And people in low SCS groups might develop dementia at different ages than those in high SCS groups. And this is actually the case. This is actually the case. So basically, if we have a prospective analysis, you can see that those who are in low SCS groups are actually have 2 times higher risk of developing dementia than those in high SCS groups. So let's combine these 2 different findings. This is the scenario how it likely happens. So basically, education and these things make a difference in peak performance. Then we saw this more rapid decline in high SCS group than in low SCS group. But in our analysis, we started from this time point when the dementia diagnosis was given. And that analysis did not take into account that there was actually a difference in the age when these people get dementic. And so when we also combine the prospective finding, this is how it's likely to look. And this actually, in a way, reminds us another theory which have been very influential, and it's the compression of morbidity theory. Because so this is the original Fry's compression of morbidity theory. He was thinking, what is the outcome, what people would like to experience when they live longer? It is that they would like this kind of compression of morbidity, in that sense that even if they live longer, they also live longer without any morbidity. So the morbidity is only a short period before death, rather than just having a longer life, but start of the morbidity at the same age. Now, if we just in a way replace morbidity with cognitive decline and death with dementia, we exactly get this kind of figure. I think I need to actually stop here because our time is up. So thank you for listening. And I think now it's time for questions.
Thank you so much. That was really, really fascinating and so rich. And I know we just have a few minutes, so I think what I'll do is provide some of the questions that people have asked. And if people can stay on a little bit longer, you're more than welcome to. And of course, if you have to go, we'll be sorry to see you go. But I'm just going to ask the questions in the order in which they came in. So we had a question on whether a widely accepted and validated composite measure of SES exists. So the question is there such a measure that takes account of different SES measures all at once? Or is the research primarily based on individual SES measures looked at separately?
All right, so I don't know any universal SES measures. So Whitehall has used employment grade because it's an occupational cohort, so everyone has a grade. And because this grade is related to many different separate indicators of SES, it's related to education, it's related to their income, and it's related to their social standing. And usually when we look association between different SES indicators and health outcomes, the occupational status is the strongest. It was also the strongest predictor of dementia in these results. But I'm not aware of any universal gold standard here. And obviously it depends on the population too.
Okay, thank you. We had another question saying, you did a great job talking about the negative factors that affect physical health and outcomes. Have you found any factors that are protective against unhealthy outcomes?
Yeah, so this part, I personally have done very little. Actually, my research has been more disease oriented, unfortunately. But I've read with great interest, for example, Laura, your papers. And so.
Well, we suspect those factors are also patterned by SES quite strongly, but people look at that less frequently. We've been trying to promote a social epidemiology of positive psychological well-being as well.
It would be good. Yeah,
the problem is that those measures are not included in many of these large cohorts, so it's actually really hard to look at. But hopefully that will change. And the last question that maybe we'll just squeeze in here is, what kind of interventions do you suggest the public health community implement to shrink the gap between low SES and high SES dementia risk?
Yeah, that's the big question actually. In the original Black report, which is we started from. I think there were something like 37 different suggestions. Now then there have been this Axison report and then Marmot reports, social determinants of health commission, and then these European reports. They all have very comprehensive thinking behind what should be done, and I think the idea is that there should be some kind of holistic approach. No single risk factor is the way to reduce these differences. So I think that's the line to look at. We did once a paper, it was actually published in the Lancet 2008, but it's very little cited. What we did a simulation model, and it was on Whitehall I, and we simulated all kind of interventions which can be done using Whitehall I data and looking cardiovascular mortality. And what would happen if you have these kind of universal population level interventions to everyone, does it remove social inequalities? And I think the answer, I mean, interventions up to primordial level, so really, really intensive, and it was a modeling. And what we saw that we can answer that, does it remove social inequalities? Absolutely, but not relatively. So that's the one part. But anyway, so it's a big thing, and that's, for example, Michael is now traveling all over the world and having discussions with governments and prime ministers about these things, and they are trying to find ways of decreasing social inequalities, but it's hard. It's very hard, as you see.
Absolutely. Well, thank you so much. You've given us a lot of food for thought, and perhaps you can send us the citation on that last paper you were just talking about. We'll share that around, where you said you looked at the, possible effects of the intervention. Yeah, and I will just say on behalf of everybody, thank you so much for taking the time to share this really, really important work with us, and I look forward to seeing more of your work.
Thank you.
Okay.
Thank you very much.
Bye-bye.
Bye-bye.